So the goal of mechanical circulatory support is to restore cardiac output and preserve end organ function. You're trying to take over the work of the heart. So everything I'm going to talk to you about today, we're primarily thinking about cardiac output when we talk about hemodynamic parameters and what the goal of the actual intervention is. Most of the time, when we're talking about cardiogenic shock, particularly in the post-MI patient with cardiogenic shock, in addition to just providing cardiac output, you also want to offload the left ventricle. So if you have someone who comes in with a massive anterior MI, has a STEMI, we revascularize them, but they're in shock as a result. The left ventricle, the myocardium, is now experiencing reperfusion injury, and they're usually volume overloaded. So the ventricle gets stretched, and therefore the myocardial demand is higher. If you can actually offload the left ventricle, shrink it down, decrease the LVADP, that's going to promote healing because you're going to actually decrease oxygen demand and therefore get better oxygenation. So ideally, mechanical circulatory support in the setting of an acute MI will actually offload the left ventricle. You're trying to optimize that balance between supply and demand and then allow time for recovery of the ischemic or stunned myocardium. So the choices that we have, and again, I'm mostly talking about in the setting of acute MI, but these tools can be used in other settings as well. The choices we have are balloon pump, ECMO, extracorporeal membrane oxygenation, and a percutaneous VAD, ventricular assist device. So I'm going to go through each of these different options and just tell you a little bit about them. Again, this is just to kind of spark your imagination and show you what's out there so you don't see a patient with it and think, I've never even heard of that before. So all of these things have to be inserted into the vasculature. And depending upon where you are and what the local expertise is and who is responsible for putting these things in, that often dictates the choice of what you end up doing. So in my training, we never put in Impella devices. Here at Jewish Hospital, that's probably our go-to for mechanical circulatory support. So it really depends a lot upon who you have and what's available to you. But I want you to know about what they are a little bit. So balloon pump is a pneumatic device, blows up and deflates in the aorta. It goes in retrograde through the femoral artery, and we put it retrograde up the aorta. It's very easy to do, relatively speaking. In terms of what it actually provides, I put in parentheses here cardiac output because it doesn't actually provide cardiac output. You may see an increase, and we'll go through that mechanism, but in and of itself, the balloon pump is not actually providing direct cardiac output, so don't let anyone tell you that it is. They're lying if they say that. It's easy and quick to put in. You don't get hemolysis. You don't get much bleeding. It's literally just an arterial cannula in the artery. The same way if you accidentally put a cordis into an artery, it's pretty much the same size as this. A tandem heart is something that's fallen out of favor in most places because it's quite difficult to insert. It's a centrifugal flow device. You put in a cannula into the femoral vein, and then you transeptal puncture into the left atrium. So that's not easy to do. You can't do it at the bedside, unlike the balloon pump. It gives you a good amount of cardiac output, takes a while to put in, has some bleeding and hemolysis. It's only been approved for 6 hours. If you put these things in, they always stay in for longer than 6 hours, but that's what's been approved. The Impella device, again, I'll show you. This is also retrograde through the aorta. Pretty simple to put in. They put 3+. That's easier these days. Provides about 2.5 liters per minute. Doesn't take as much time. But here you used to get a lot of hemolysis. That's gotten better in the newer models. And then finally ECMO, which is sort of the kingpin because it's full support. Centrifugal flow device, you have, depending on if it's venous to venous or venous to arterial, you have 2 cannulas. One to take the blood and one to give the blood. It's relatively easy. You can actually put someone on this on the bedside. The cardiac surgeon will. It's full cardiac output support. So what do each of these look like, and what are the pluses and minuses? Who has ever had a patient with a balloon pump? Anyone taking care of a balloon pump? Okay, so some of you. So we will sometimes have them here at university in the CCU, depending upon the patient, and then over at Jewish we'll sometimes have them too. So the idea of a balloon pump is it's just a catheter that has a balloon wrapped around it. And the balloon inflates during diastole and deflates during systole. So what that does is, in diastole, remember that's when the coronaries are perfusing. So when this balloon inflates, it blocks the blood, and so therefore more blood goes backwards and through the coronaries. So this is a great choice if you have someone who comes in with an NSTEMI and they have left main disease and you're waiting for them to get a surgery. We'll usually put in a balloon pump because the balloon pump will help to increase the coronary flow. So one of its main uses is to augment coronary flow. That's a good reason to use a balloon pump. This also has the effect of raising the diastolic blood pressure. So here's my normal blood pressure, right? Here's my dichrotic notch, systole, diastole. My diastolic blood pressure will raise at the beginning of diastole and will actually lower at the end of diastole because you get a vacuum effect. So it raises diastolic blood pressure. Keep that in mind for a second. Now, in pre-systole/systole, that's when it's going to deflate. When it deflates, it creates basically a vacuum effect. So you pull more blood forward, and this effectively afterload reduces the heart. So systole here, as you can see, is a little bit lower than what the normal systole is. So the cool thing about that is it decreases systolic blood pressure, increases diastolic blood pressure, and the map stays the same or sometimes gets a little bit better. There is no medicine we have that can do this. There's no inotrope, there's no afterload reducer, there's nothing that can effectively increase one of the blood pressures, decrease the other, and keep the map the same. So that's the power of the balloon pump. The main power is number 1, coronary flow, and number 2, afterload reduction. So this is a good device if you need afterload reduction, but you don't have any blood pressure room to accomplish it. So examples are decompensated heart failure. You won't see us use this often, but that's possible. Aortic stenosis, severe aortic stenosis. This is going to afterload reduce to let more blood go out. And then sometimes we'll use it in mechanical complications of MI, like mitral regurgitation. If I can afterload reduce you, then my blood is going to go forward instead of backwards. So we'll sometimes use this for mechanical complications of MI. So again, this does not give you increased cardiac output. The only way the cardiac output increases, anyone could postulate a mechanism by which my cardiac output might effectively increase. How could it possibly be doing that? Any ideas? Perfect. If you afterload reduce them, then the cardiac output can get better simply because the ventricle is pumping against less. So it does not directly provide cardiac output, but you can sometimes get a little bit extra. So keep that in mind because I'm going to show you the randomized controlled trial for balloon pump and cardiogenic shock and why it doesn't work. But now you know what it actually does hemodynamically, and so therefore you can use it appropriately. Yeah. Yes, you can use a balloon pump for refractory ventricular tachycardia. There, you're basically trying to augment, decrease afterload and augment cardiac output by any means that you can, but usually that's just going to be a bridge and a very temporary thing while you're trying to get everything else under control. Now, sometimes a balloon pump will get put in the cath lab when the patient is crashing and burning and the blood pressure is low and we don't really know what's going on. Sometimes a balloon pump will get inserted in order to help go through the procedure. And then we have to deal with it in the CCU afterwards. So there are times when it gets inserted because we don't exactly know what's going on and we need some quick support, and we'll put the balloon pump in and then sort through the pieces later. These can be put in at the bedside. It can be put in blind. And an important note, if you ever have a patient with a balloon pump, what do they need every morning? A groin check, yep, and sure to make sure they're not, although there's not much hemolysis with a balloon pump. How do you know where the balloon pump is? Chest x-ray, and you want to see at the top of the balloon pump there's a little radio-opaque marker, and it should be basically at the same level as the carina, which is going to be just before the aortic arch. So you want the balloon pump tip here. You don't want the balloon pump tip up here. If it's going around the curve, it's not meant to do that. So you're going to cause trauma to the aorta. Also, if it's too low, the balloon pump, depending upon the length, might cover the renal arteries. If you see hematuria in a patient with a balloon pump, you got to get a stat chest x-ray and worry that the balloon pump is too low and you're actually compromising renal blood flow. They end up with decreased urine output and hematuria. So those are two important things to check every day on these patients regardless. Even if you don't think it's moved, everybody gets a chest x-ray. What might you think are contraindications to putting in a balloon pump? When would this be dangerous or more harm than benefit? Good. Aortic regurgitation. Why? Right, because this is open during diastole, so you're just going to be pushing all the blood backwards into the ventricle. So AI is an absolute contraindication. What else? In general, if you have a very bad aorta, so lots of atherosclerotic disease, either at the aorta or at the femorals, it could be hard to get this in, and you don't really want to be crushing against a very atherosclerotic aorta. So that's a relative contraindication. And then what about if you have an aortic dissection? Would this be a good way to afterload reduce the heart? No, bad idea. You're just going to propagate the dissection. So those are the main contraindications to balloon pump. Any other questions on this? One other comment, because you'll see these in the CCU and you'll go like, oh, there's a monitor. I don't know what to do. And then you'll back away. If you have AFib, Well, the way that the balloon pump knows how to inflate is based usually on the EKG gating. So we have an EKG leads that are on the patient, and then the device times the inflation based upon the EKG because it knows when ventricular systole and diastole are. If you have AFib and you have a varying RR interval, therefore varying lengths of diastole, the pump can get real confused. So it will be trying and going and trying and stopping and going and going. So AFib with RVR makes it very difficult for the balloon pump to find where it should inflate. And so then we can sometimes troubleshoot the timing, manipulate it manually. That's above the level of this discussion. But just beware that it might not be doing you that much good if you're in AFib. Okay. So moving on to our next kind of support that's available. I went from the least invasive and the least amount of support to the most. VA ECMO. Ooh, mama, I love this. Okay, so this is VA, venous to arterial, because there's also VV ECMO. In VA ECMO, we put a giant straw, like, you know the boba teas, when you have those giant straws? Put a straw about that size into the vein, femoral vein on one side, and that's what we're going to take the blood out. The catheter gets the cannula gets threaded all the way up to the right atrium. So we're taking out all the venous blood. The blood goes through, this is the centrifugal pump. This is a VAD. You know, you've seen patients with VADs. This is a VAD. It's just external. So it goes through a centrifugal pump VAD, and it goes through an oxygenator, and then goes back into the femoral artery, and the cannula actually usually goes up and sits about midway through the artery. And that's how you get blood body perfusion. Now, some of you are going to raise some questions. What is the first thing you wonder when you hear that? I'm delivering the blood right here. How does it get to the head and neck? Nobody knows. It does. Usually these patients are lying flat, and it's kind of remarkable because I'm delivering the blood right here, yeah? And so it should be all going down to the lower extremities. But you actually do get retrograde perfusion of the head and neck, which is pretty cool. This is essentially bypass, right? When someone goes on cardiopulmonary bypass in the OR, this is exactly what they do, only they have a giant machine for it. So this is bypass at the bedside. That's how I describe it. This provides full support. It's providing full cardiac output, and it's doing the job of the lungs. So this is the option that we use when someone is in refractory cardiogenic shock complicated by pulmonary edema. The heart doesn't work, so I need to bypass the heart, and the lungs are full of fluid, so I need to bypass the lungs. This is a really, really late stage, only do it if you have to kind of therapy. Oftentimes, if we're putting people on ECMO, they're in such bad shape the survival is not good. I have a decent record. I had 1 week where I put 2 ladies on and they both survived, but that was really unusual. I've also used this for a massive PE that caused a woman to die, and when we got her back, her RV was so blown. So we put that woman on VA ECMO because then I was offloading her right heart and bypassing the entire circulation and oxygenating her while the heart got better, and that worked. VV ECMO is also an option. So VV ECMO takes the blood out of the venous side and puts in oxygenated blood back into the venous side. That's what we use for, can use for like ARDS, for example. So if the lungs are terrible, but the heart works just fine, you could potentially just deliver oxygenated blood into the right side of the heart, still go through the pulmonary circulation, but not require oxygenation. There's a couple of problems with VA ECMO or VV ECMO. So the problem with VA ECMO, if I'm using this for someone who comes in massive MI, for example, I had a patient, massive MI, VSD, crashing and burning. Needs circulatory support, trying to die. So we do VA ECMO, but remember that I'm delivering the blood here. And remember at the beginning I said that one of the goals of mechanical support is to offload the left ventricle that needs to heal. ECMO loads the left ventricle because I'm delivering the blood into the aorta and it retrograde fills into the ventricle. So this is actually a volume load, which is not great for the myocardium. But sometimes you do it, you have to, and we don't have any perfect therapies. So that's all I'll say about ECMO, but it's a good backtrick pocket that I've used in dire circumstances, both for pulmonary reasons and for cardiac reasons. Any burning questions about ECMO? They do this in the babies a lot. It's a very different story in them. Their survival is much better. In adults, by the time you get to ECMO, you're very, very sick. Okay, other options that exist. The Impella. So the Impella is a neat device. This is the left-sided Impella. It goes in through the femoral artery, retrograde up the aorta, and we just deliver it like this into the left ventricle. So right here is a blood inlet. It sucks the blood in, And right here is an outlet. It's a motor and an outlet, and it pushes the blood out. So it literally just takes the blood out of the left ventricle and spits it into the aorta. So this is a good option if the primary problem is low cardiac output, but their lungs are okay and no other problems. So you take the blood out of the left ventricle, deliver it into the aorta. This device is very positional, so one of its problems is it can move. And if I move and this goes into the left ventricle, I'm just taking blood from one chamber and keeping it in the same chamber, so that's no good. And if it moves this way, then I'm just taking blood from the aorta and putting it into the aorta and not doing anything. So the movement of this device is what has caused it to be problematic historically. The new design is actually a little bit better. It tends to sit a little bit better, so it's actually a good option. And this is oftentimes what we do. Let's say someone's going to go and get a VT ablation. I don't know how much you guys know about VT ablation, but you have to put the person into VT to find it. And this is my impression of an EP doctor's job. Beep, 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 right? So they're on a treasure hunt, and it might take them hours to map. Don't tell them I said that. Actually, I've told them that before. It's fine. It's a sophisticated version of that. So they're trying to find the VT, and so they have to put the person into VT for long lengths of time. How well do you think that's tolerated, especially for someone with a bad heart? Not very well. So we'll often put in the Impella for support before a high-risk procedure like a VT ablation or even a high-risk PCI. So if I'm going to do a high-risk PCI of the left main, you might put in this device to provide support during the procedure. So this is used both for procedural support, but we can also use it in the ICU. Oh, let me go back to ECMO for a second. Nope, I forgot what I was going to tell you about ECMO. If I think of it, I'll tell you again. I don't remember. So this is the Impella device. You can't use this if the aortic valve has something wrong with it. So if there's AS or AI, you probably can't really use this device very well. Otherwise, it's a relatively large cannula, but not as big as ECMO that goes into the artery. This has to be done in the cath lab because you have to have x-ray guidance in order to tell where it is. Hot off the presses, brand new, just approved, is the Impella RP. This is pretty awesome. This only provided left-sided support. What if I have a patient who's had an inferior MI, RV infarct, and the inferior wall of the LV? Left-sided support might help me, but really if I'm struggling with RV failure, this does absolutely nothing for me. Who's taken care of a bad RV infarct? A couple of you have with me recently. Anyone taking care of a bad RV infarct? Who was on the team? No one who's here. Okay. They are really, really sick because they're hypotensive and you can't get the blood from the right ventricle through the lungs into the left ventricle. So these people are really hard to take care of and really, really sick. And this device does nothing for me at all. Inotropes, the RV doesn't really respond very well to inotropes, so you can get into real trouble with these patients. So here comes this new device that's newly approved. This is the same thing, but it's on the right side instead. So now this goes into a vein. It goes up. It takes blood from the vena cava, and it spits it into the pulmonary artery. So it's just the reverse design, which is pretty cool. So there are some places where they double dip. They put in an RP and they put an Impella in the left side, and now you have full support for both sides of the heart while it's recovering from its MI. You shouldn't do this if you have a pulmonary embolism. You don't really want to be sticking the catheter through the PE. But for a bad RV infarct, this is kind of cool. The other use for this is sometimes when we do VADs, left ventricular assist devices in patients, the RV fails and you're really sunk. So this can be a temporary support for the RV. So this is really cool. I haven't used one yet, although I thought about it the other day. Also has to be put in the cath lab, cannot be repositioned once it's in, but it's a device that we have in our back pocket for right-sided failure. A note on these. You should not be putting in any of these temporary devices unless you have an idea about what's the next step, right? So if someone is end-stage heart failure, this is not the device that helps you. If they're end-stage heart failure waiting for a heart transplant, okay, now I have somewhere that I'm going. Or if this is an MI complicated by cardiogenic shock and I'm hoping the MI is going to recover, the myocardium is going to recover, then I can do these devices. But these are not to be used for people who there is no next step for them because this is all temporary. I should also mention the Impella costs $25,000 a pop. So again, you don't just want to be throwing these in willy-nilly. Okay, any questions about Impella, either of those things? Again, this is just for fun. It's exciting so you can see that these devices are available. Tandem heart is used in some centers where they have a lot of experience with it. I've only had one episode with this ever. So this is also a VAD, an external pump. But here what they do is they come up through the femoral vein into the right atrium, and then transeptal puncture into the left atrium, and they take the blood directly from the left atrium. So you've now completely bypassed the right side of the heart and the lungs, take it out of the left atrium, and then deliver it back into the aorta. The benefit of this, when we talked about wanting to bypass the right side of the heart, that can be a benefit, but I really don't see much benefit to this device over the others that we just talked about. It's really difficult because you have to make a hole in the septum. You can go the wrong place and accidentally get, into the pulmonary artery, whoops, or the aorta, whoops. So these take a long time to put in and are kind of out of favor in most of the places where I've worked. Okay, so those are the devices that are available. These are the things that I think about when I'm in the CCU and I have someone in refractory shock. In the back of my mind is always the question, do I need to escalate to mechanical support? So now I'm going to take it back from all these advanced things just back to the straight up balloon pump, and I'm going to show you the evidence about what happens when you put in a balloon pump. So this study was done in 1973, so contemporary. CARE is really the same now as it was back then. That's a joke. And this is a study of 87 patients. This is where we got our data from initially. 87 patients, acute MI with refractory cardiogenic shock on inotropes. So they put the balloon pump in, and so this line is diastolic blood pressure. So pretty much the diastolic blood pressure goes up. This line is systolic blood pressure. Pretty much it goes down. And then this is the mean arterial pressure of the circle. So this is just to show you this is the first time we really understood about what it does. So it raises diastolic, it decreases systolic, and keeps the map the same. What you can see, though, is that whether you survived or whether you died, that's the open circles versus the dark circles, really the degree to which it changed your hemodynamics did not at all impact whether you survived or not. When we looked at what actually happened to their cardiac output, some people's cardiac output went up, some people's cardiac output went down. So again, no reliable change in the cardiac output. And then lactate extraction, pretty much all of them had better lactate extraction with the balloon pump. So then we looked through and said, okay, what evidence exists for balloon pump usage in cardiogenic shock? This is really commonly inserted. I mean, there used to be a time when balloon pumps were put in almost every acute MI patient that came in who was a little bit hypotensive. And it did have a class 1 recommendation only because we didn't know what else to do. But this recommendation was based on these non-randomized studies, and they thought that selection bias was a confounder, right? Because if this person wasn't that sick to begin with and got the balloon pump, then maybe they did better than the person that the interventional just thought was going to die and so didn't bother with the balloon pump. So in this, we really didn't know what the data really showed. So they took a look at all the randomized controlled trials that reported mortality at 30 days. This was only for the indication of acute MI and cardiogenic shock, right? So that's only one indication for which we put in the balloon pump. There were not very many studies. 2 of them that was balloon pump versus standard treatment, and 3 of them that were balloon pump versus one of the other devices I told you about. That was the attempt of these makers to get those devices approved. The mean duration of support was 60 hours, so that's interesting to see how long these people needed it. And in this database of randomized controlled trials, 85% of them had revascularization. That's not modern. In the modern era, this number should be 100%. So if you look at these trials, they're all over the place. This one shows that balloon pump has improved mortality. This one shows balloon pump has worse mortality. So these were all over the map and really didn't give us an answer. When you looked at the pooled information, balloon pump versus no balloon pump, no difference in mortality. Balloon pump versus other VADs, no difference and no change. So this really was not supporting that balloon pump would be helpful. So the next step was the balloon pump SHOCK II trial. It was published New England Journal 2012. So this is very modern. This is during my training that this came out. So they decided to test whether the routine use of balloon pump in cardiogenic shock as a complication of acute MI would reduce 30-day mortality. Okay, this is the kind of stuff that we like to do. However, all of the patients had to have early PCI of the infarct-related artery because that's the modern recommendation. You always go and revascularize first. Don't wait for the shock to get better. You revascularize first. So what did they see? Well, 600 patients, pretty decent-sized study. They had to meet the definition for cardiogenic shock, so low systolic or low MAP, greater than 30 minutes, or the need for catecholamines of some sort. They had to have evidence of pulmonary congestion and impaired organ perfusion, so they had to be in shock. Interestingly, they excluded people who were resuscitated for a really long time because those people have such a bad outcome anyway. They didn't want to confound the data. If they were comatose, they got excluded. If they were so bad that they already had gone to some other form of mechanical support, they were excluded. If their shock had been ongoing for more than 12 hours because the cat's out of the bag. Severe vascular disease for the reasons we discussed. AI for the reasons we discussed. And old just because those people tend to do worse. So this is a pretty well-designed trial. What did it show? The balloon pump could be put in before or after they opened up the artery, whenever the interventionalist decided. They allowed crossover if the patient had a mechanical complication of the MI. I told you why it's good in mechanical complications because of afterload reduction. Primary endpoint, 30-day death. Then you had some safety endpoints. Okay, so they assumed 56% survival in the control group. That's how they powered it. Dun, 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 dun. No difference. No difference for a therapy that we were doing routinely. And this is 30-day mortality. So then if you look at any other outcome, repeat heart attack, stroke, some complication from putting in the balloon pump, bleeding or sepsis, no statistically significant difference in any of those very significant clinical outcomes. Then if you look at, okay, well, but did they get better? Did their body get better faster? No difference in lactate levels, no difference in GFR. And if you look at pretty much anything except for L-VAD, no difference in how much of catecholamine or inotrope they needed, no difference in how long they needed the inotrope support. Remember I told you it doesn't actually provide cardiac output, so this makes sense. They still needed all that inotropic support. There was a trend towards more people needing a VAD in the control group. That we don't have an explanation for that. So basically the routine use of balloon pump is now not in favor any longer based on this trial. That said, people still do it. And it's still tempting because you have nothing else you can do for these patients and you don't want to pull the trigger all the way to an Impella. So you'll still see it happen, but the data does not support routine use of balloon pump for cardiogenic shock. For me, what does this mean? Well, I'm often, if I'm not in the cath lab at the time of the decision, it means I'm pretty aggressive about weaning them off of the balloon pump once they come to the ICU because I know that I'm just putting them at risk for complications without giving them much benefit.